back there? This is great. I love the sound effects here. Thank you all for coming. This is a wonderful opportunity, and I appreciate the chance to speak with you all. Just curious, when you saw the flyer about tonight's talk, what kind of things ran through your mind? Intimate wellness, and was it something that was of interest? Was it like, is this racy?
Hormonal replacement therapy.
Okay, yeah, that's a big one. That's a big part of what we do. Anybody else? Anything? Well, I'll just kind of give you a little plug about some of the things we talked about, and I don't want to steal too much thunder from my colleagues that are going to be speaking here on other nights. I'm a urogynecologist. I'm the owner of Swan Medical Intimate Wellness. Practice started in Los Gatos, and we've been there for about 10 years now, almost 10 years. We just opened a new office here in Danville, a second office, last July.
6 minutes away.
Yes.
Yeah, and you guys all got a gift card. If you're in the U versus U challenge, you have a gift card. And if you're not, I can I might have an extra.
In the old Victorian medical offices, a 901. Yeah.
I think every dentist is medical.
Yep.
So what is intimate wellness? Intimacy is not just, intimate concerns are not just about intimacy. It's also the things that we keep close to our chest, the things that we don't talk about, the things we're nervous about, or think are taboo or stigmatized, and you think you're alone in. And a lot of those things fall under the umbrella of the urogynecologist, whether it's incontinence or prolapse or sexual dysfunction or pelvic pain, or all the things that don't seem to fit anywhere else, but it's all within this small area. And the prevalence of these things are extremely high. So just to give you an idea, 30 to 50% of women will have some form of urinary problem, incontinence, urgency frequency. 40% of women will have some sort of degree of prolapse from childbirth or chronic forces, which I want to get into today, because of exercise and our drive for fitness sometimes can be underguided in a lot of programs. So I want to bring that to attention. And then, of course, there's time and aging. There's life events that lead to pelvic floor dysfunction. So a lot of these things are so common. 50% of the population has, 50% of the female population will have some degree of pelvic floor dysfunction that impacts intimacy and activity level and the way we age, and of course how we choose to live. So without getting into every single aspect of what we do, I wanted to talk to you about how women and men really should embrace aging and how they can embrace aging to live better as they live older. We're all living longer. We're well over 85 years of age, average age now for women, which means that women are living a half to a third of their life in menopause. And that's a bit of a problem because most of your lives, for women, most of your lives are supported by your sex hormones, which have a finite lifespan. Your sex hormones are produced from your ovaries. 85% of them come from your ovaries, and ovaries have a average lifespan of 51. So average age of menopause is 51, means you've gone a year with that period. And we've defined menopause incorrectly. If you go a full year without a period, that means you're now postmenopausal. But before that, you were premenopausal. What happened to perimenopausal, and what happened in the 10 years before that? Why is it that the symptoms of perimenopause last 8 to 10 years? Interestingly, it's a very easy answer, but no one seems to be talking about this. Your ovaries make two main sex hormones, testosterone and estrogen. And I bet you didn't know that women make 10 times more testosterone than estrogen. Same as men. And evolutionarily, it's necessary because your ovaries make 85% of your testosterone. Testosterone levels drop between 30 and 40, like 50%, because it's based on the ovarian size and the ability to create testosterone command. It's not like estrogen that is cyclical every single month until you stop. It's produced on the body of the ovary by the vast majority on command, on demand. When you're aroused, when you're in a marathon, when you're being chased by lions. So testosterone is a performance hormone that comes from your ovaries, 85% of it. So memory, sleep, libido, drive. Think evolutionarily. Forage for food, procreate, defend the tribe. By 30, you're no longer that person. By 30, evolutionarily, that's the grandparent raising and raising the children. They're not the ones that are fending off the marauders. So the problem with that is now your performance hormone drops off between 30 and 40, which is why memory, sleep, libido, drive start to slip in the 40s. But it also coincides with a lot of things that other things that happen. Our kids become teenagers. Our grandparents become older. Finances get tight. Businesses get hard. And marriages are now in their 10th or 15th year, and things are getting tight, are tough. And we think that, well, of course I feel this way. Life is hard. But it wasn't that hard 10 years before that. The reality is we start to get weaker in those years. It happens to both men and women. Men go through andropause, women go through menopause. But that 30 to 40 window is a really hard one for a lot of people because that's where we start to have struggles. If you think just in the workforce alone, who's the most valuable employee in these big companies? It's the person who's in their 40s and 50s. They've been there for the long time. They've been through the long haul. They're the ones leading the companies. And unfortunately, women are the ones that are leaving the workforce too early because lack of accommodations or fear of retribution if they ask for accommodations because it's hard. So I always say 50 is the new 30s now. We're getting older, we're living longer, and we really need to embrace this period. Not just accept it and age gracefully, but accept that this is changing, that it's happening, and figure out how to fix it. So a lot of the things we do in our practice is about enhancing, improving, optimizing our day-to-day performance, our health, so that we can live better as we live in life. It's sort of like an umbrella term for what we do at Swan Medical. The intimate part comes with intimate concerns come with a lot of things that happen as a result of life events and pelvic floor dysfunction from childbirth. Childbirth is a beautiful process. It's an amazing process that the body can do such things and can restitute mostly. But if you think about what the pelvis supports, we are now erect. We're not on all fours, which means all forces go this way. So if you think about the pelvic floor, there's one major muscle group which is made up of several muscles called the levator ani. It's your trampoline that supports everything from within. And it's a muscle group, unlike your other skeletal muscles that are attached at insertion and origin that move things. It's within a cage, which is your pelvis. And the pelvis, between that and the trampoline that supports everything, is attached within that pelvis. Childbirth forces and hormonal changes during pregnancy allow the pelvic floor to relax. That's why joints become very loose when you're pregnant, especially as in the last trimester, and allows things to dilate and relax, and even the pubic bone can become more flexible to allow for delivery. And then afterwards, over the course of a year, things restitute. Whatever doesn't come back is what leads to changes, whether it's discrete tears, detachments, stretch injuries, or just changes in dimensions impact something. Either it leads to incontinence in 50% of women, leads to prolapse in 40% of women. Close to a quarter of them will require surgery. And of course, sexual dysfunction it starts early and just gets worse from then on. Typically at a rate of 40% of women will have some form of sexual dysfunction. And dysfunction doesn't mean terrible can't have it, but it could mean that it's impactful, meaning it's no longer pleasurable, orgasmic decline starts to happen. Or when things change hormonally, painful intercourse, UTIs, vaginosis, and of course, who wants to have sex with that? It's just uncomfortable, it's painful, and it's a big deterrent. I'm hoping I'm painting a picture of how a lot of the things we do are really integrated in a women's life through life events. And what I hope to do we believe strongly that education is empowerment, and nowadays there's no reason for us not to be informed. That's why we're getting younger and younger patients coming in saying they don't want to be like their grandmother. They don't want to wear diapers, and they don't want to worry. They want to continue running. People are coming in earlier to understand how they can prevent some of the things that have happened to their parents. From a urogynecologic perspective, a lot of the things that we see day to day, bread and butter things are, I can't jump on a trampoline anymore, I can't play with my kids, I can't go running. How do I fix that? There's a myriad of ways of addressing that, from surgical and non-surgical, depending on what the severity and the causes and what the patient's interests are. And one thing that we have as urogynecologists is a huge toolbox. We have lots of options for addressing a lot of these things. And as technology has evolved, we've become even more, We have more robust options that actually yield very good results. 80, 90, 100% success rates for most of the things we see, which is fantastic. If you think 30 years ago, before my specialty existed, failure rates for those surgeries were 40%, success rates were maybe 50% for incontinence. We didn't have any great answers. So that's, so from a pelvic floor dysfunction issue, it's an extremely common problem that many of it can be addressed. Now, just to transition to fitness and how this has become a concern. Especially here in California. I came from the East Coast. We weren't as fit over there. But here, everyone is, there's a wonderful place like Spenga, throughout the state. And there's all kinds of places and organizations that foster fitness. But they're not always guiding correctly. So there was a great study that a colleague of mine did on CrossFitters. Average age of 30. And of those women, most of them, I think maybe 60 or 70% of them, had no children. Over 50% of them had incontinence. And it has to do with chronic forces in the pelvis. So somebody who has chronic constipation, or an asthmatic, or a smoker, you can imagine all the forces that go here. So who knows what a Valsalva effort is? So Valsalva means closing your throat, bearing down. Picture what you would do if you're straining for bowel movement or pushing to have a baby. That's a Valsalva event. So if you're bearing down, all forces go this way. We do it to pick up things heavy. We do it to move something really that's awkward. We're trying to leverage our bodies, support our back by embracing our core. But it's really not, it's not a muscular thing we're doing. All we're doing is blowing up the balloon in the abdomen to stabilize the back. But by doing so, where's the force go? This way, to the trampoline. And the trampoline can only hold so much when you do that over and over and over and over. So the challenge with lack of proper training in fitness routines, particularly with strenuous heavy weights, has to do with improper form. Valsalva events during a squat, during a lunge, during anything, and especially if you're doing heavier and heavier weights, puts force in the wrong way. So it's very important. It's probably something that you all are aware of because you're here. But always exhale during the hard part. And it's a challenge because we're very accustomed to doing that for bowel movements. And we're accustomed to doing that for leveraging our back for when we move or pull something heavy, but it's not a very good technique. Men develop hernias, women develop prolapse. Where's the outlet? Where's the weak point? So thinking about that, I've worked with groups down in the South Bay on how to really educate, particularly athletes, on how to protect the pelvic floor so they continue doing all the hard work. Because you don't want to stop exercise. You don't want to stop running. You just want to do it better. So you ever remember this trick where you have to rub your belly and pat your head? I had to practice this earlier today. It's not easy because, same thing when you're doing a Kegel. Kegel doesn't move anything. It's that trampoline within a cage. So if you squeeze your pelvic floor muscles, all you're doing is pulling the levator ani, that trampoline, forward. It closes the rectum, closes the vagina. There's 3 muscle groups that surround the vagina and rectum, and they pull you forward. And when you passively strain, even if you're exhaling, that trampoline gets lax and forces go there anyway. So what I recommend is, when you're doing something strenuous or hard, not only avoid holding breath, exhale, but also do a Kegel at the same time. So you're literally doing this rubbing and tapping motion at the same time. But you'll discover how easy it is to do. It's just about being conscious about doing it. Because the whole goal is to stay fit. Keep your pelvic floor strong. Keep your back and everything functional. But when we do things incorrectly, we're actually weakening. It's sort of like wearing a brace when you're Valsalva, because you're not using your muscles to do anything. You're actually blowing up the balloon. So that's tip number 1. For urinary issues. And I'm just going to, and actually, because it's a small group, any questions along the way, please just interrupt me because I'll just ramble on and on. And I'm ad-libbing this as we are. So if you have any questions about anything, just please interrupt me. Urgency. Urgency, frequency. Ever see that commercial? I haven't seen it in a while, but a commercial where the bladder's chasing the woman around. It's the cutest thing ever, but it's a miserable thing to have. Unfortunately, 30% of women have that. And a lot of that happens as a result of hormonal loss. So remember that average age of menopause is 51. That means that you've stopped having a period, which means estrogen is stopped being produced. So your total estrogen supports all of your connective tissue, which brings blood supply to all things that have receptors. If you lose estrogen, there goes blood supply to those tissues. Those tissues, what's the thing that supports them, are the capillaries. Capillaries support all the nerve ending. The bladder is very sensitive to that. Urgency, frequency is a urethra and a bladder problem that starts from a neurologic decline, kind of like diabetes, but it's just called menopause. So what happens is when you lose estrogen, your blood vessels can't support the nerve endings can't do the work. So urgency, frequency, urgent continence happens because now the relay doesn't work. A third of women will develop that. It's an enormous number. It's not a small consideration. And yet, people don't know that. People don't know that they can do something about it. First of all, how about restore some estrogen locally? That usually helps a lot. But then there's other things that can be done for both conservatively and through medical management and such. But one of the tips I want to share with you, for those who have this or that know somebody who's always constantly running the bathroom 12 times a day, 15 times a day, 5 times at night, or can't get into a car without going to the bathroom and has every bathroom along their route and every mall mapped out, is the whole concept of pelvic floor exercises, Kegels, is actually a very important tool for that type of incontinence. It helps if you're about to sneeze and you can engage, but a good belly laugh, you're not going to be able to engage your pelvic floor muscles enough to stop it every single time. But when you have urgency and frequency is, imagine that you're literally typing or you're washing your dishes, and just the sound of water or pulling in your driveway, and you feel that, oh, how am I going to make it to the bathroom? So you stand there and you got your legs crossed and you're trying to make your way to the bathroom. That's not going to work because you're not doing it. And then if you get up and run to the bathroom, which is a knee-jerk response, you're going to lose. The bladder is an extremely strong muscle. And the thought that my bladder is weak, that's why I can't make it, is actually the opposite. It's an extremely strong muscle that gets stronger because the leash is off. And it's now just contracting all the time. So whenever you get that sudden urge to go, stop where you are, squeeze, and wait. And when you wait, you will actually suppress that urgency because that action turns the bladder off. That's what it's supposed to normally do, but it doesn't work. So if you actively engage your pelvic floor muscles to do a Kegel exercise and sustain it during that process, wait for the urgency to go away, you've just turned off the problem. Now you can walk to the bathroom. But don't get up and run. So I guess that brings me to something I should have discussed before, is what on earth is a Kegel? Yeah, less than 50% of patients get it right. And we all know how to do it. Everybody knows how to do a Kegel, but we've given it a name that must mean it's something different than what we've been doing. We all know what it's like if we have gas. And what do you do if you have gas? I call this the Brad Pitt test. We're going to crack up about this. So if you're in an elevator and you have gas, and Brad Pitt walks in, what are you going to squeeze? You're not going to contort your body. You're literally just going to squeeze your anus, and you're going to hold on for dear life. That is a Kegel. That's a Kegel, but we've given it a name, and it's this mysterious thing. And I have patients that ask me, "Do you want me to squeeze the front or the back?" I said, "Well, if you can do that, I'll give you a medal," because it's the same muscle group that pulls forward. So a Kegel is literally pulling your levator inner forward, and all it is squeezing your anus into your head gas. But it's so funny that providers explain this incorrectly. Tell them, when you're in the bathroom, try stopping your stream. First of all, that's how you set somebody up for failure. You know how strong the bladder is? When it's going, it's almost impossible to do. And if you already have weak muscles, it's not going to work. So patients do it. Secondly, you're setting up a dysfunction. When you're urinating, your pelvic floor has to relax in order to happen. Try urinating by hovering. A lot of women have been taught to hover in public bathrooms. It's hard. It doesn't go unless you push. And you're pushing because your pelvic floor is like this. The whole thing has to happen by your pelvic floor relaxing. But if you're doing a Kegel when you're in the bathroom, you're actually creating a dysfunction. So don't do Kegels in the bathroom. Do them now, where you're sitting. Literally, nobody will know. It doesn't move anything. I know, everybody on three.
Remember that soon.
Yeah.
So Kegels are just like holding gas. Do that throughout the day, throughout your whole life, because it's something that's very important to maintain, because bodily function may not be so easy as we get older. But that's a key tool for if you're about to sneeze and you have strong muscles, you've already learned how to gauge them, that's when you use it. But if you have urgency, overactive bladder, that's how you stop your bladder from taking control of your life. So, tip number 2.
Does the same apply for nighttime frequency? I mean, waking up 3-4 times and just.
That's a little harder because you're unconscious, you're asleep. You're not even aware of it until it wakes you up.
Yeah.
Hopefully it wakes you up. And that's
Yes.
If it doesn't, that's a whole other problem. But it's also dangerous.
My dad would say it depends.
But the challenge is that your bladder doesn't know, and your bladder is an extremely obedient organ. It's normally paralyzed all day long. Your bladder is a very, very, very strong muscular bag that we trust to hold urine. And who designed this? But it's always paralyzed. Your brain keeps it paralyzed through your relay center in the low back, and it's off, off, off until it fills enough and it's telling the brain secretly, I think I gotta go. The brain says, okay, point made, noted, I'll let you know when it's time. And it has no choice but to stay paralyzed. Well, and then when you feel that you need to go or you finally have the time to go, you actually walk to the bathroom, take off your clothes, sit down, and the leash pops off. The inhibition comes off. So the bladder only has one option to do is contract. It's all it knows how to do. Well, now imagine that leash is weak. That relay starts to fail. The brain can't keep it turned off. So you hear the water run, you pull in your driveway, put your key in the door, and you're like, okay, I don't know if I'm going to make it. That's the problem, is the bladder is extremely obedient, and simple triggers, just like with the way we raised our kids by running the water run in the bathroom, it's a simple, primitive instinct for the bladder to contract under those circumstances. But as adults, that brain keeps it inhibited, but then as we get much older, or whenever that starts to happen, we start to revert the other way. So it's important to learn how to control that. Urge suppression is the technique. Kegels are the exercise. So patients, because we do a terrible job of explaining this, Kegels is exercise. Urge suppression is the game. So picture a soccer player that goes to the gym, works out every day, gets very strong, gets very fast, but never learned the game. Who cares how strong and fast you are? So Kegels every day is only useful if you know how to use them. You get that sudden urge, stop, squeeze, wait. Once it goes away, now you're controlling the breath. And if that's not enough, there's all kinds of therapies that we offer for that can help. But that's going to be a baseline minimum requirement for anybody with that. So I mentioned estrogen loss being a part of this. Neurologic decline happens with age, mainly because we're losing our hormonal support. And estrogen supports all of your connective tissue: skin, bones, hair, heart, vagina, bladder, urethra. Anything that is connective tissue is dependent on estrogen, and when that goes away, things change. That's why osteoporosis increases by 50%, cardiovascular disease and heart attacks and stroke goes up 30% right after menopause. Atrophy, vaginal dryness, painful intercourse, urgency, frequency, what falls under GSM, or genitourinary syndrome of menopause, happens at a rate of 50 to 70% within 5 years of menopause, which impacts intimacy and impacts activities. So little estrogen in the vagina goes a long way, but sometimes it's just not enough because if we start too late. Unfortunately, most of my patients show up 5 to 10 years later, and it's been going on for a while. But we can reverse a lot of those changes because of new technologies. Estrogen is always going to be the first place to start, and it'll be a forever thing. And we're just talking about local. I've even talked about systemic hormonal replacement. It goes a long way. It's literally like a magic wand to maintain vaginal and vulvovaginal and urogenital health. Okay. Who else? Yes.
How does it help with UTI protection?
Oh, that's a great one. So UTIs are much more prevalent in women than men because of proximity. But yet it doesn't happen to everybody, and it doesn't happen all the time. Why is that? The vagina is a completely different environment it is very different than anywhere else. The anus, the perianal tissues, and the GI tract are basic pH, so 7 and above. The vagina has a pH of 4.5. It's acidic. It's very acidic. And the only reason it does that is because estrogen in the tissues supports, puts glycogen or glucose in the cells. So, you know, our skin is, I don't know if for those who understand skin, stratified squamous epithelium. So it's meant to be abraded, it's multiple layers, and it's meant to slough. All those little cells that slough have sugar, glycogen. Lactobacillus loves glycogen. So lactobacillus lives in the vagina because there's glycogen put there by estrogen. Because what happens when the estrogen goes away? Glycogen goes away. There's less cells, there's more micro tears whenever you have UTIs, whenever you have intercourse, and the loss of estrogen and loss of bacteria, now the pH is higher. So now you don't have a protector. So now all the bacteria, enteric bacteria, which is 80+% of the UTIs, are caused by bacteria from the GI tract. And because of proximity, the environment, and any little trauma, they can get in. So that's why UTIs are far more prevalent in menopause than they are even in honeymoon cystitis. It's just because the environment's different. Guess what fixes that? Estrogen. It's amazing how something so simple that the body's naturally made has been demonized for 22 years. So I won't go on that route. That's a whole other talk. But that's just local.
What about estrogen with history in your family of breast cancer?
Excellent question. For 22 years, we've been led to believe that estrogen causes cancer. I say 22 years because at 2002, I was chief resident in New Jersey, where my chairman was one of the co-authors of the Women's Health Initiative. Women's Health Initiative was the landmark study that was meant to prove, designed to prove, that women need to be on hormone replacement therapy after menopause to protect their heart, their bones, and their brain. That was the whole purpose, because we were doing this forever. We knew it was necessary. 40% of the menopausal population was on hormone replacement therapy before 2002. Well, the study was stopped short because there was one arm, and there's multiple arms in the study. There was one arm that showed a slight increased risk of breast cancer. And the study got stopped because of safety regulations. They had to stop the study early because there was a slight increased risk in one arm. But when you stop a study that wasn't powered for that to begin with, and you don't even get numbers, now you're not only, you weren't powered to begin with, now you're severely underpowered, so the conclusion now are not really valid. But a non-significant increase was reported as a significant increase in an arm that had nothing to do with estrogen. It had to do with a synthetic progestin. Because the arm that had estrogen only, even the synthetic, had an all-cause lower mortality for all types. Cancers, colon cancer, breast cancer, heart disease. What happened? So 22 years ago, media runs, landmark study stopped early, hormones cause cancer. What does everybody think? Estrogen. And to undo bad news, even if it's incorrect, is almost impossible. And it took 22 years for a lot of people to make a lot of noise and dissect and tear apart the study over and over and over again before finally all the societies have agreed that estrogen is necessary to protect our women as we're getting older. And now the conclusions by all societies regarding hormone replacement therapy is to start early and don't stop unless you have to. So to get to your question, breast cancer was never caused by estrogen. The confusion happens with the study and then what happens with breast cancer survivors when they have estrogen receptor positive tumors. So the breast is just like bone, is rich in estrogen receptors. So of course, if there's a cancer, chances are it might have estrogen receptors. So when you have a breast cancer that has estrogen receptors, what do you want to take away from the tumor? You want to take away what it wants. If we could take away oxygen just from the tumor, you could, but the rest of us would suffer. So you take away what it wants. So you sacrifice the body for the tumor potential regrowth, because the whole goal of breast cancer is to eliminate it and then don't support it. So patients come home and they hear, well, my doctor said I have breast cancer and they take away my estrogen because it caused my cancer. It didn't cause the cancer, but it can support it. So that was a huge myth, a huge misconception that has still lingered today. But now, to get to the breast cancer history, 80% of breast cancers in women are non-genetic causes. purely because of age-related changes. When does that? Most cancers happen as we get older. Colon cancer, breast cancer, prostate cancer. These occur with age because as we age, mutagenic changes happen at the cellular level because we're no longer supporting our bodies. And we're living far past the way we were designed. So as we get older, cancers start to happen. So what's the treatment for those cancers? Take away what it wants. If it's prostate, take away testosterone. If it's breast, you take away estrogen. So those are the standard of care, which is under a lot of scrutiny now, because over 90% of breast cancer patients are survivors, which is insane. It's a big fear. 2% of the population has a risk for breast cancer, baseline, no genetic history. Of those, 90% of them will survive. But yet, we treat them all the same. You have a breast cancer, we're going to take away your estrogen. But now you're going to die of a heart attack. You have a 30% increase of heart attack. That year, you have a 50% increase of osteoporosis and fractures, which will then be your other likely thing to get you. And if that doesn't get you, then of course dementia. 8-1 for women over men. And not to sound lame about this, but the reason why this is so important, why this is so, I don't know, it's baffling, is that just simple math. Simple math about we're living longer and we're not doing anything about it, but we're chasing fears that we're misled. So now the recommendations are start early, don't stop, prevent the things that you can prevent, treat them as they come along, but don't just let age take over, because we'll lose. So hormone replacement therapy is back on the table, although right now we're at a low of 4%. 4% of postmenopausal women are being treated. It's insane. And that's changing because now there's a lot of very outspoken, much better spoken people than I that are out there on cameras and media and creating a lot of noise. And now the societies have changed, now things are changing at the FDA, they're taking black box warnings off the estrogen, at least they're trying. So hopefully soon that'll change. And now the other question, the other hormone that we haven't talked about is testosterone. So 50% of your testosterone is lost between 30 and 40, which means that our performance centers, which is our brain, the primary role for the testosterone is brain support, breast cancer prevention, muscle mass maintenance, and therefore weight management. And of course, performance at the brain level means all the things I talked about. How mental agility, mental and physical and energetic stamina throughout the day. And like I mentioned, many high-performing people are in their 40s and 50s that they don't have time for this. This is not the time to be weak. This is the time to be strong. This is the time to create businesses. This is the time to raise your family, not accept the way things are going to go. So testosterone is an extremely important hormone for me, not just me. The FDA genderizes hormones because they do studies on a medication. They have to pick a demographic. They want that in, just like Viagra. Viagra works in women too. It's not just for men, but that's the demographic they studied it, so that's the only thing they can recommend it. They do the same thing with testosterone, they do the same thing with estrogen. Men can't live without estrogen. We'd all have heart attacks if we did. Which is why men were dying earlier of heart disease, because loss of testosterone leads to loss of estrogen. Men get their estrogen from the testosterone. Women get 15% of their estrogen from the testosterone. So testosterone supports a lot of things. Now it's really, there's several countries around the world that have a formulated, commercially available testosterone. They've tried several times in the US, hasn't happened. I'm willing to bet that within the next 10 years, there will be a commercially available FDA product for women here in the US. Nonetheless, for now, it is available, but it's off-label. Off-label means anything that has to go through compounding, that does not have FDA stamp of approval, that this has been tested for this. Doesn't mean that there's not studies. There's hundreds of studies on testosterone in women dating back to early 1900s. And it's not, testosterone has never been new. It's just that it hasn't been supported here. So it's foreign to us. But a lot of women benefit greatly from testosterone replacement. So to give you an idea, we have a pretty broad range of patients, anywhere from 18 to 98. the vast majority fall between 40 and 60. But 40 to 50 are premenopausal still. They're only getting testosterone because of performance needs. The other 50% are above 51, and they're menopausal, and they're both getting estrogen and testosterone. And then, of course, of the small 2% of the population that have breast cancer that come to see us, they're getting testosterone with or without anastrozole as a way of preventing the estrogen conversion so they can still perform and still keep their bones strong, and still keep their muscle mass, which is necessary, not just accept survival as punishment, because that's sort of the way it is right now. Take away all estrogen, now you have to deal with that. So I don't think anyone breast cancer survivor should sacrifice quality of life for survivorship, because what's the point, right? It's not just about living, it's about living well and being present and being showing up for our family and at work and our friends. So, any other questions?
How does progesterone fall into all of that?
Yeah, progesterone is a necessary hormone in the ovulatory cycle. These are great questions. In the ovulatory cycle, and the whole purpose for an ovulatory cycle is to procreate, and if it didn't work, try again. So if it didn't work, you slough, you start over. Progesterone is integral in that, because when you have a progesterone drop-off, it causes, think of what the lining of the uterus as bricks, like a brick wall. So you're building a brick wall, what's going to hold it together is your mortar. So the mortar holds all the bricks, and as the lining thickens, it gets stable, it stays stable, but then when you lose the progesterone because the pregnancy didn't happen, the mortar goes away, then the bricks fall. So that's the lining of the uterus. So progesterone is necessary in the cyclical form. It's also necessary for breast mass maintenance. It's the reason why breast mass volume decreases with age, and why mammograms are more recommended over as you get older, because they're less dense. When they're young, mammograms are hard to read. You can't find anything, so that's why you always do ultrasound in young women, because progesterone maintains the tissue integrity of the breast. Aside from that, it helps wonderfully with sleep. It's just a great hormone. When it comes to hormone replacement therapy, the absolute requirement for progesterone is if you have a uterus and I'm giving you estrogen. That's the absolute requirement, because your uterus is just a recipient. All it does is want estrogen. It doesn't care how old you are, it doesn't know that you're menopausal, it doesn't care where it comes from. So if a postmenopausal patient, if one good thing that comes out of menopause is not having a period, gets estrogen unopposed without progesterone, that lining will build, the brick wall will build, and there's no mortar. So then they will have periods again. So if patients not on hormone replacement therapy, a postmenopausal patient should not bleed because there's very little estrogen. So that's why the assumption is if there's postmenopausal bleeding, assume it's cancerous or proven otherwise, meaning evaluate. Vast majority is usually benign causes, polyps, fibroids, things like that, or estrogen effect because they're on estrogen. And they forgot to take the progesterone, usually the case. So progesterone is important. We use it a lot for patients for menstrual cycle regularity, for PMS symptoms. Even our young patients, we'll put them on progesterone in a cyclic way to offset the drop-off, because the estrogen surges is what causes all the moves. Yes?
Hi, so can you tell us a little bit about your journey as a urogyne, and now, you have a very untraditional practice that, and also I'd love to know about your name too.
Yeah, sure. Well, it's interesting. I did an interview at a Miami radio station the other day, and she wanted to know about me, and I thought it was going to be like about science, or what we would talk about. She said, "No, I want to know about you. Where do you want to start?" So we'll start with when you're a kid. I'm pretty old. I mean, it's a long time. So can we narrow it down?
You postmenopausal?
I mean, past that. So my parents are both Colombian. So I was born in New York, and but I've never lived in Colombia. But I've only spoke Spanish at home. My wife is from Mexico, so we only speak. And I lived in Guadalajara for 4 years, so my Spanish dialect is more Mexican than Colombian. My journey and how I got here, basically, I'm an OBGYN resident. I was OBGYN trained, but I've always enjoyed the quality of life concerns that patients have, because there's a lot of lack of information in women's health, a lot of dismissal, a lot of gaslighting, a lot of, oh, that's normal. And since I was in OBGYN, I've always found the need to educate women. What are they doing? Why are they here? Why are we going to do what we're recommending instead of just being paternalistic? So I think my career has lent myself to urogynecology because it's riddled with lack of information about that. Through my education and training, I've always worked in big box systems, and then I moved here and I taught with Stanford, and I worked at Kaiser, and there was just no opportunity to teach. It was always just they throw the patients at you, wait for the shoe to drop, fix it, and move on to the next. And I didn't like being a fireman. And a lot of the concerns that my patients would ask me about, I didn't have time to ask or address, and I didn't have the knowledge on how to do it. So when I left Kaiser 10 years ago, in 2014, I opened a practice and expected to have a flood of people coming in. And when you leave a big system, you can be top dog and it doesn't matter. You get out there and you're nobody really fast because nobody knows you. And I had patients coming in one a week, sometimes one a day. And then I remember having patients that would kind of rush me because they're so used to being rushed. They would ask me, say, I know you have to go, but I have a question. I said, go for it, I've got plenty of time. and I would just listen. And something very interesting happens. In medicine, we call it the door handle question. When you've got 1 million patients waiting, and you're already behind, and you're trying to get out the door because you get up to the next one, and you're trying to be fair to the one that's waiting for you, but you also don't want to be disrespectful. You got your hand on the door handle and say, doctor, I have a question for you. So we call it the door handle question. It's always the one they've been dying to ask, and they can't ask, but they felt comfortable enough that, you know what, if I don't ask now, I'm never going to know it. So you gotta sit down and you're gonna be late. Well, now I have all the time in the world for all the door handle questions. So I started listening to the patients, and they started explaining to me what their true wants were, not just the needs, not just why they were referred. They want to know why this is happening and what can they do about it. Because I love my partner, I want to be intimate, or I don't know where my brain is because I keep forgetting where my keys are, where I walk into a room. So just listening to all these things, they just want to feel better. They want to live better. They want to love better. They want to do all these things better. But whoever asks their patients how they feel or what they want, they don't have time. So it sort of started there. And as a result of that, we started in a small practice, joined space with another doctor, and then we opened up our practice in Los Gatos 10 years ago. And with that, we kept that same model. We allow patients to speak. We allow them, and we also learned ways of getting information about the wants that they're afraid to ask. 30% of women don't even, their partners don't even know what they're experiencing. And a third want the provider to ask. We don't ask them, we don't know what to do about it. So that's a challenge. So what we've done is we create a way of intake, and maybe you remember the intake. It's all the questions.
Yeah, detailed intake forms.
Our patients always say, nobody's ever asked me these questions. And it's questions that, why would anybody ask? Because they're just expected to be normal. But common doesn't mean normal, just common means common, and it doesn't mean you have to live with it. So we talk about all kinds of things. Our intake is about sexual health, bladder health, bowel health, appearance, hormonal symptoms, and it's basically a screening tool that gives me permission to ask. And with that, I can ask about whatever they want to talk about. And so we allow enough time for our patients to kind of explain what their concerns are. We educate, we evaluate, we come up with solutions, and there are lots of options.
Do you take insurance, commercial, and Medicare?
We do take Medicare, we do take PPOs, but no HMOs. And we do see, in the area, Kaiser has 40% of the market share, so they don't have anywhere to go. We also see it's probably a good 25-30% of our clients are Kaiser patients because they're not getting answers there. So we do see them, and we do make things accessible as best as we can. We work with insurances in any way that's possible, like blood work, initial consultations for many of the things that we talked about tonight would be covered. Some medications, anything I can prescribe through a pharmacy, even at Kaiser, it gets covered. But things that are compounded, that are off-label, things that are beyond what insurance insurance considers, sufficient, so it usually isn't, it is a self.
And you're in Los Gatos and here, and do you have, is your practice here to you, and then what's the
Yeah.
practitioners
Yeah,
here?
thank you.
Yeah.
I want to talk about my team. We have
Yeah.
an amazing group of people. They're brilliant, they're best at what they do, and they're the kind of people that you would feel comfortable sharing information with. So Carlos, for example, is our director of aesthetic medicine, so it's one thing to just feel better, but guess what happens when your body is better? You look better, you look healthier. And you also identify the things that have changed over the years. So Carlos is going to speak to you next week or the week after.
I think you're are you the third one?
I think he's the third.
Yeah, I think so too.
He'll be here in 2 weeks talking.
Yeah.
Awesome. Well, Carlos is amazing. He and I have known each other for several years now, and I'll share a little bit about him. He's a nurse practitioner on his way to his doctorate now, and he's a trainer for Allergan Aesthetics, which is Botox fillers, and he'll say more. Laser therapies through Cyton. He's a research nurse for Cyton lasers, which is how we met initially doing studies together. He oversees all the research projects, but he's also a trainer for them. So he understands about resurfacing and about skin lightening, about melasma, and all the things that happen to our skin over time. And a skincare expert, a lot of background information, a lot of background experience in dermatology. So when he speaks, you'll understand what I mean. He's really amazing. Elizabeth.
Next week.
Yes.
Elizabeth Cooper.
Cooper. For some reason, I just wrote my name. Cooper. We called her Copper for a while there because they misspelled the label on her door. But Elizabeth Cooper, she's been in the community here for about 17 years. She's an expert in male and female sexual health, weight loss, and hormonal management. She's been great. She's got this cute Southern accent, and she just has the right answer for everything. And I don't know. I just love speaking with her because she has a great personality. It's very, very charming.
She'll be speaking next week.
Yeah. What's her topic going to be on next week?
Hers will be on hormone replacement therapy.
Oh, great. Okay, great. Hope I didn't steal too much of her thunder then. Have to give her a heads up. And then we have Josephine Du. She's another urogynecologist. She came on with us last September as a fellow. She graduated from the University of Oklahoma after doing medical school residency and another 3-year fellowship after that. And then yet she still decided to come on with us for another year to learn how we integrate what we do. How we integrate sexual health into urogynecology, and how we integrate menopausal management into urogynecology, because it's the same patient. It's the same patient's experiencing all these things, but we silo everything. And then, of course, the aesthetic medicine part is where she's now going to be learning from Carlos a lot. Down in Los Gatos, we have Remy Paye. She's another nurse practitioner. She's functional medicine trained geriatric family practice. Brilliant. I can only learn so much from her because my brain's about to explode every time. She has so much knowledge in her, and she's very academic, but also very, very personal. She's like a surfer. She's the coolest person. So she's down in Los Gatos, and who are we missing?
That's our providers.
Those are our providers. And of course, Janice is our regional practice manager. She oversees both practices, and then we have two other managers that have their duties. And my wife, of course. My wife is our marketing director. I call her our CEO, our Chief Experience Officer, because anything you hear, smell, touch has to have a purpose. So when you walk into our office, hopefully you'll see what I mean. It's calming, it's welcoming, it's not a med spa, and it's not a sterile clinic. I think it's exactly what it should be. So hopefully you'll enjoy that. If you're welcome to come back anytime. There's a little sign-up sheet there for any of you who want information. We can always correspond that way, or if you want to schedule a time to come see us, go ahead and fill that in, and we'd love to have you there.
And your name, the name of the business.
Oh, I'm sorry. Swan Medical.
I know, but how did you?
How did that happen?
Yeah.
This story changes so many times. I we started off as Women's Pelvic Health Institute. So Women's Pelvic Health Institute, because I really felt that there was only 2 urogynecologists in the private sector in the South Bay. So I thought that was going to be the niche. And then as we evolved to serve our patients' needs, we started with the sexual health part. Well, guess what? There's a partner that goes along with that. So as we would take care of the woman, the male partner was having struggles keeping up, or his were becoming much more obvious. When they're both having dysfunction, they're concordant. But when one's better than the other, now they're discordant because of issues. We started seeing that. So we started seeing men for both erectile dysfunction and for hormonal management. And then one day I walk out into the hallway and I hear a male voice. So I just reach around, I walk around to the front and I see that he's talking to the receptionist, but deadlocked on the sign. Women's Pelvic Health Institute, and he's trying to wrap his head around why he's here. Oh boy. This is going to be a problem. So I just walked up to him, I greeted him, and I welcomed him to practice. He felt comfortable, I got his gaze away from the sign. And that day I decided we needed to change the sign, change the name. But then what? So we came up with logos, we're drawing all kinds of things. My wife is an amazing graphic, she's a clothing designer by trade. And came up with the swan idea because the transformation and all that. And somehow that became it. So our swan logo started with Women's Pelvic Health Institute. But then we were like, what do we call this? What do we call this? And we have a swan in our logo. So we became Swan Medical. So that's how that happened. And I think that's the right story. It's kind of like how my wife and I met. Our story changes every time we have drinks we have.
Stick to one.
Yes.
Quick question. Currently are bioidenticals off market?
You mean off-label?
Off label, I mean.
All bioidenticals are off-label.
Okay.
But let me explain a little bit of this. Because this is a huge misconception, and of course, people like to draw a dividing line. FDA-approved medications means that a pharmacy wanted this to be commercially available to the public. To be commercially available to the public, you have to go through the FDA. The FDA they have a very important job to protect our people. Almost to a fault sometimes, but that's their job. So that means anybody who wants FDA approval and FDA indication for something, they have to do rigorous studies, spend millions and millions of dollars to get a product, and it has to be a narrow box that has to fit it. The gender, the age group, the disease state, and that's it. You can't say Botox works for migraines until you do studies 10, 20 years later. So you have to, they start an indication and that's it. So FDA-approved medications have, they're manufactured using the same ingredients, just by big companies that have to be FDA mandated to fall within 10% variance, meaning any random medication pulled off their conveyor belt has to be within 10% of what it is. So 100 milligrams of anything can be 90 or 110. That's a pretty significant swing, but it's hard to be perfect when you're mass producing things. But that's what they require. Non-FDA means that patients who don't fit into small, medium, large need a 6.5 or an 8.5 size. I'm just making, so like shoe sizes. So if you need a half size or a patient that uses medication that has a base they're allergic to, that's commercially available, then you have to go to compounding pharmacies to make them. Compounding pharmacies are different types. There are those that are FDA oversight and those that are FDA directed. So 503A pharmacies, which are the mom and pop compounding pharmacies that you see everywhere, those are all small batch pharmacies that are allowed to compound. They have a 15% variance. They use the same ingredients, same manufacturers, same everything. It's just that they're not seeking medications, they're just creating a medication based on the same principles to fit a patient's needs. But they're not FDA approved. So therefore they're off-label because they're prescribed for anything. But there's like things like gabapentin is a commercially available medication. That's used for off-label purposes all the time. So anything that's compounded is not FDA approved, therefore it's off-label. But it doesn't mean it's wrong. It just means that it's customized to the person. When it comes to larger compounding pharmacies, 503B pharmacies, those are FDA oversight. oversight. They literally have FDA walking through their doors every single day to monitor and make sure they maintain certain standards. But because they're not seeking indications for specific things, they have a lot more wiggle room. They just have to follow standard processes and follow them 50%, and they can mass produce just like big pharma. So it's really a misconception about what compounding means, what bioidentical means, because there's bioidentical commercially available ones. So estrace is a commercially available estradiol, but because estrace got a patent for it and did all the testing and have FDA approval for it, commercial pharmacies can't make estradiol the same way. They have to add estriol in it to make it a little bit different so that they don't get sued by big pharma. So a lot of it's politics, a lot of it's just misinformation, but what matters is the provider prescribing, understanding the reasons and how to dose and how to monitor. I think pharmacies do matter, so depending on what we're talking about, 15% variance is a big swing. So I use big pharmacies, big FDA 503B pharmacies that have a 3% variance because they don't have the big overburden of expense. They can afford to have that. So there's lots of ways of doing that. All right. Any other questions? I hope that was helpful. And of course, if you have any questions, feel free to reach out. We'd love to see you and help you in any way possible.
Yeah. And really, your $100 gift card. It goes towards services there and like consultations and checking them out. And thank you guys so much. Thank you, Dr.